Hey, Daryl Baskin here again. This is part of the San Antonio Ophthalmology course review. This is actually my rehearsal the night before it crashed last year. I wasn't able to record it, and I also need to actually get my timing right. So here we are. We're going to continue on. This is just where I used to live in Burundi. We won't hit all these pictures. We'll hit the pictures, but not the video. That was where I lived, that little house. I guess it's a big house, actually. That was the school my kids went to, and then I had this commute to work. Across like basically 2 football fields, more or less, past 2 churches. That's the eye clinic. This is the video, but I'm really pressed for time, so we're just going to go ahead and skip through it. Sorry. We're talking about this beautiful picture here. Diabetic retinopathy. It's a global epidemic expected to affect 700 million people by 2045. Although with Ozempic, maybe it's going to be a lot less. I mean, who knows? So globally, 1/3 of diabetic patients have diabetic retinopathy, and 1/3 of those diabetic retinopathy patients have vision-threatening retinopathy. Okay, there's a lot going on in this slide, but key points: chronic exposure to hyperglycemia leads to endothelial cell damage, selective loss of parasites and basement membrane thickening lead to capillary occlusion, subsequent retinal non-perfusion. This is most of what I think of when I think about diabetes. It's certainly about all I explain to patients when they really want to know. Here's your spectrum of diabetic retinopathy, and we're going to hit on the definition. So mild NPDR, think for a moment, how do we define it? There's a couple different ways. I like the easy way, that's MAs only. Here's some microaneurysms on path. How do we define moderate NPDR? Really easily, more than mild, less than severe. We're not going into DRSS here. I don't think that's worthwhile unless you're involved in research studies, and you don't need to know that for OKAPs or your board exams. So here's a picture of some microaneurysms, some doublet hemorrhages, a cotton wool spot, and same thing here with some hard exudates thrown in as well. Okay, so how is severe NPDR defined? So we talk about the 4-2-1 rule. Think about it for a moment. Oh, there's one with the first one. So 4 quadrants, severe intraretinal hemorrhages as at least 20 and MAs and/or MAs. Definite venous beating in at least 2 quadrants, and prominent ERMA in at least 1 quadrant. All you need is one of these criteria to meet the 4-2-1 rule, and you have severe NPDR. There's a picture of what that looks like for DBH. Now we've got venous beating plus some ERMA right in the center. Venous beating is obvious. Here's some more venous beating. This is from my friend Dr. Garg. And so what's the prognosis when one of the 4-2-1 criteria is met? That would be severe NPDR. Prognosis is it's a 15% risk of developing proliferative diabetic retinopathy with high-risk characteristics within 1 year. Okay, about 1 out of, what is that, 7. What if you hit 2 of those? So now you have very severe NPDR. So now it went up to 45% risk within a year. So you have a 50-50 chance of having something that could destroy your eye within a year. All right, so how do we manage NPDR? Okay, what do we do? Somebody comes in with some doublet hemorrhages, some ERMA. Do we observe? Do we do PRP, VEGF inhibitor, systemic options? We got a lot of options now. Okay, so we'll hit PRP first. We studied this a long time ago. Folks with PDR or severe NPDR are randomized to PRP or control, and lo and behold, 5 years, 50% reduction in severe vision loss. ETDRS in the 90s, before most of you were born, PRP was not recommended for mild to moderate NPDR, and type 2 diabetics benefited more than type 1. I don't want to worry about the second part. Overall, for severe NPDR, and especially if they're diabetic type 2, or if they're likely to be lost to follow-up, I would do PRP. Otherwise, I'd follow. VEGF inhibitors were looked at in DRCR protocol W, and there's no difference in visual acuity outcomes. They did reduce the risk of PDR CIDME with vision loss, but they didn't actually make a difference in visual acuity outcome because they had rescue therapy. It's not like you're going to just watch these patients go down the tubes, right? This also assumes you have good follow-up. Panorama study, I think this is sponsored by Regeneron. Yeah, periodic aflibercept versus sham, basically very similar protocol W, but there's, again, no difference in visual acuity outcome. They looked at DRSS steps, but those are reversible. Those are temporizing at best, and everybody knows anti-VEGF wears off. And the problem is not all the patients know that. They think, I got my shot, I'm good to go. And then they go and they don't come back till they're blind. So the BCSC states that there's a lack of clear long-term benefit, and I agree, don't do it. Don't give a patient VEGF inhibitor if they have NPDR. I don't think you're doing them much of a benefit, and you're, if anything, giving them a false sense of security. Okay, Give them surgery. Well, we're not quite there yet, but we are doing a study on that, looking at PDR. I put stars there because I think that's important for you to know, and I have a few more stars coming up for the diabetic stuff. Systemic options. So I don't think you need to know these studies. At one point I thought you did, but I think it's too esoteric. We all know that glucose control is good, and type BP control is good. Do we need to know the studies that prove that? I'm not sure. Accord eye and field eye, I think you should know those because those showed that fenofibrate slows DR progression, and we are studying that in DRCR protocol AF right now. And then if you lower the A1C too much, higher mortality rate. So I tell my patients, if they get below 6, they might be hurting themselves more than helping. Pregnancy anemia and severe carotid artery disease can further exacerbate DR, something I bring up frequently with my patients. So there's my star, there's my star. Okay, next up. Diabetic macular edema can occur at any point. Some people think it's sort of like a independent pathway versus the progression to PDR. Maybe some patients are never going to get PDR, they just get DME or vice versa. And certainly a lot get both. 36-year-old male here, history of diabetes times 14 years, 20/50 vision. Here's his OCT scan. He has intraretinal subretinal fluid, right? How do we treat him? What are our options? We could observe. We could do FMG, that's focal macular grid laser, steroids, anti-VEGF, or vitrectomy. All right, so let's look at laser first. Early on, it was found to be helpful, again, the 90s. But nowadays, it's really not first-line treatment for most. It is still useful if they have non-central leakage, or if they're medically unstable or unlikely to adhere to near-monthly anti-VEGF injections, or if they're really needle phobic, which a lot of patients with needle phobic are also laser phobic. We're going to hit potential AEs later, but just know you can cause problems with laser. Laser scars expand. You can increase transiently macular edema, paracentral scotomata. I've had patients come back with that. Not my patient, not yet anyway, not that I know of. Inadvertent foveal burns, bad stuff. Micropulse is unproven. Don't let anybody tell you otherwise. Treatment of peripheral non-perfusion with sectoral PRP does not help DME. We thought it did for a while. Okay, so let's talk about VEGF, anti-VEGF. So in this study, we have 5-year results from protocol I. And if you notice, anti-VEGF is way better in terms of letters on the visual acuity scale than is laser. Okay. Protocol T, the 1-year results, this is a cohort, and oops, got a little trigger happy there. Subgroup analysis with baseline vision 20/50 or worse. There was a difference between aflibercept and the other two. So if you're initially, we said after protocol T, 1 year and year results, well, 2 years similar, but not quite the same. If you're worse, 20/50 or worse, aflibercept's the best. Now I have a 71-year-old lady. I tried to enroll her in something called protocol AC, which we're not really going to get into. She failed by 1 letter. She was 20/50 plus 1. This is her OCT scan. Let's pretend like she had 20/40 vision though, okay? So now look at the subgroup analysis from protocol T where we compared bevacizumab, ranibizumab, and aflibercept. It really didn't matter which one you gave. They all ended up about the same. So, and that was also true at 2 years. Okay, let's keep going. So protocol I, let's just review. This is the first phase 3 trial to demonstrate that VEGF inhibitors are superior to laser for DME using best corrected visual acuity as an outcome. RIDE-RISE, VIVID-VISTA basically also showed anti-VEGF is good. And then protocol T, we kind of went over the main things, but here the star is if there's no difference between the 3 first-gen drugs. If they had good vision, if they had poor vision, then aflibercept was better. Here's a 48-year-old female, no history of diabetes that she knew of, 20/20 vision, and she's got these findings. We see some dot blot hemorrhages, maybe some MAs. We see some kind of radial peripapillary hemorrhages and a little bit of some blurred disc margin here. So is this diabetes? No, this is a CRVO. Here's her OCT I observed. I told her to come back in a couple weeks. 3 weeks later, she had this, which is what I feared. A lot of macular edema. And I still wonder, should I have just treated her prophylactically? I think we talked about it and she declined. But the point is that we don't really know. Some doctors do, some don't. We don't know who's going to get macular edema and who's not. Anyway, that's RVO. We'll get back to diabetes. So not everything that walks in your door is going to be diabetic. And some people will say they don't have diabetes and have diabetes. So I think everybody here should be able to list off 3 entities that can present with features of NPDR. I just showed you a CRVO, radiation retinopathy, ocular ischemic syndrome, MACTEL2, mild coats, hyperviscosity, And my new favorite one, retinal vasculopathy with cerebral leukoencephalopathy, RVCL. This is basically a genetic disorder that causes an endotheliopathy. Really interesting. So they don't have diabetes, but they'll look like it. Not in the book. Okay, so protocol T 2-year results with 20/50 or worse vision. What I want to point out here is that this is the thought process. Did I say we weren't going to talk about AC? We're going to talk about AC. So aflibercept and bevacizumab, there's a difference. Aflibercept and ranibizumab, not a big difference. But then look at the very beginning. Everybody got better. Everybody got 6, 7, 8 letters of vision those first few months. So the question then was, well, hey, if everybody gets better no matter which medication they get, even if they're 20/50 or worse, maybe we should start out with a cheaper one and then switch to a more expensive one. So this is comparing an initial management strategy, which is different than just comparing one drug to another drug. So you can see the difference in cost there. That was in 2022. I'm not sure what the difference is now. So patients with 20/50 or worse vision either got aflibercept monotherapy or they got bevacizumab first with the option to switch to aflibercept at 12 weeks or more if their clinical response is unsatisfactory. And look at that. They ended up the same. So bevacizumab first actually beat them, not statistically significant. So protocol AC, no difference. Good to know. And you save a lot of money. So let's summarize. I didn't talk about this, but Rise, Ride, and Vivid Vista, they allowed patients in the sham arms to cross over. And when they crossed over, they never caught up to the original group. So if you delay anti-VEGF when they really need it, vision's lost forever. Frequent VEGF-I in diabetics actually increases the risk of death by 3. We don't talk about that a lot, but Vivid Vista, Rise, and Ride all had a 3x risk of death in month 12 to 24, actually, not in the first year. So start all diabetic patients, DME patients on bevacizumab with some exceptions. And we'll come back to some of that in a moment. Let's talk about steroids for just a bit. Remember this protocol I information from 13 slides back? This is the 5-year results. I told you that anti-VEGF is better than laser, and you could see here that we had triamcinolone plus laser way down here at the bottom. Well, we reanalyzed that, just looking at the 2-year results, and we only looked at the pseudofakes. And look at this. The green's down here. That was, what was it green? Sham plus prompt laser. But then purple was ranibizumab, and then blue was triamcinolone. The triamcinolone group is just as good as the ranibizumab plus prompt laser. So it's interesting that if you just look at pseudofakes, then your visual acuity scores are pretty good, which kind of gets to the fact that steroids cause cataract. And so maybe we're just seeing cataract effect in the other patients where the steroid didn't do as well. So next up, we just talked about that. Protocol U, we're not going to go into, but essentially all these patients had chronic DMEs and they probably got treated too late. So steroid use has benefit for DME, just worry about glaucoma and cataract. Someday we'll find out a study that shows us exactly how to use it. And vitrectomy, it's been done, it has not been studied well. Maybe outside the US this is done better, but anyway, for now it's not standard of care. So here's a patient, 55-year-old male, history of diabetes just for 3 years, 20/25 vision. He was referred to me for his DME after his cataract surgery. He was very unhappy with his vision. He thought the cataract surgeon screwed up. So here's his OCT. What do we have here? Not diabetic macular edema. That's not the way DME presents. There's no hyperreflective foci to speak of, and it's basically this cavitary lesion. You have loss of ellipsoid zone, also something you wouldn't see so abruptly with healthy ellipsoid zone on either side of that lesion. You don't get that with diabetes. So this is not diabetic macular edema. This is MACTEL2. Here's a 40-year-old male, history of diabetes for 10 plus years, great vision, 20/25 plus. So which DRC or retina protocol would guide management for this patient? Well, all the ones we talked about so far had 20/30 or 20/40 or worse vision, or 20/32 or worse vision. Nobody can tell you what to do with 20/25 plus. So we developed a protocol for that, and it's called Protocol V. You can remember it, V is for very good vision. And so we did an initial management strategy comparison. So started off with anti-VEGF, aflibercept, if I recall correctly, laser, then rescue anti-VEGF, or we did observation, then rescue anti-VEGF. So basically anti-VEGF from the get-go, laser plus rescue, or observation plus rescue. And there's our rescue criteria. And you can see basically at the end, the cumulative probability, over 60% of patients in these groups never, in the two observation and laser groups, never needed anti-VEGF for the first 2 years. And how'd their vision do? Oh, I thought I had that coming up. Maybe it's coming up later. So maybe I must have deleted that slide. Bummer. Anyway, their visual acuity came out the same. The key thing is there wasn't a big difference. So you can observe these patients that they have very good vision. PDR, defined as neovascularization, vitreous hemorrhage, preretinal hemorrhage. We can further break it down to no high-risk characteristics. High-risk characteristics are advanced. HRC is right here. I have another slide coming up on that. 1/4 to 1/3 disc area of NVD. Any NVD with VH, half disc area of NVE with VH. I think you should know that, although it's probably less important these days. Advanced PDR is basically extensive VH, TRD, ptysis, or nucleation. So here's one of my patients who I just saw again the other day, who had a really bad PCO. But anyway, nice lady. We saved her eye. And there's that slide showing all those things. Here's a 46-year-old female, no history of diabetes, referred by a great optometrist in town to me, 20, 30 plus vision. What is this? This is diabetic retinopathy. You can see the NVD even on her OCT. You can see it, of course, on her right over her disc. Here's the OCTA. She doesn't have an enlarged FAZ. Kind of fits with the fact that she's pretty asymptomatic. But then on her wide field fundus angiogram, you could see extensive capillary non-perfusion and some small areas of NBE, and then of course her NVD. So how do we treat her? We have a protocol for that. It's protocol S. We compared PRP to ranibizumab for folks with PDR, and we found at 5 years they had about the same level of visual acuity, and a lot of them were lost to follow-up, almost 40% in each group. So anti-VEGF is not better than PRP for visual acuity. In fact, for all the reasons I said before, it's temporizing. It gives a patient a false sense of security, and it doesn't permanently keep the neovascularization from coming back. It does have a place, don't get me wrong. I'm a big combo therapy proponent. So also, 40% of your patients aren't following up. Would it have been better for them to have gotten PRP or anti-VEGF, right? Especially if they don't follow up for a long time. And then we also saw that initially at the 2-year mark, this is a visual field total point score. Basically, the lower you go, the worse. So ranibizumab, they held on to their visual fields peripherally, but then the prompt PRP people lost it. That theoretically, that should all be due to laser. But then over time, they basically got a lot closer to each other because we know the diabetic retinopathy takes away peripheral vision because it causes peripheral non-perfusion. Okay. Diabetic retinopathy study, goodness, we randomized eyes to photocoagulation, no photocoagulation, that had really bad PDR, severe, we talked about this one earlier, and it reduces risk of severe vision loss by 50%. So what are 2 major risk factors for developing retinopathy? Just put them up on the screen: diabetes, duration, and the severity of the hyperglycemia. So A1C and how many years they've had diabetes, and what 2 medical conditions are definitely associated with worsening DR, hypertension, dyslipidemia. Another good question for tests: how often should women with gestational diabetes be examined? And that is not required. There's no increased risk. Here's some of the studies that we looked at. I put stars next to the ones I think are the most important: I, S, T, V, and AC. And this wraps up the section on diabetes. And remember, always wear your eye protection. Thank you very much. Bye-bye.